Good afternoon, everyone. So today, myself, Dr. Rajan Patel, I'm a chief intensivist and lead the ICU at Rhythm Hospital. The today's STAT session is about sepsis, what you should know as an intensive care nurses. So sepsis is a very routine thing in our ICU, and I'm sure you guys handling septic patient in a day-to-day practice. And your role as an intensive care nurses is very much important in resuscitation, stabilization, and even outcome of the patient. Today we have Dr. Supriya Patankar. She is a consultant intensivist at Dinar Lankeshwar Hospital, Pune. She did her DNB in medicine from Pedi Hinduja Hospital, and she also did DRNB critical care from the Sri Hospital. So today she will let us through the session. In the end, we'll have some MCQs. You type answers in the chat box, and then we'll discuss. Okay. So let's go ahead. Dr. Supriya Patankar, are you ready?
Yes, sir.
Yeah, please start the session.
Okay. So today's topic of discussion is sepsis, what ICU nurses should know. Moving on with the introduction. So sepsis remains one of the most time-critical emergencies in the ICU. It is a dysregulated host response to infection, leading to life-threatening organ dysfunction. ICU nurses are often the first to recognize red flags and initiate sepsis bundles. This session focuses on the knowledge as well as practical skill nurses need to know to improve outcomes. Our learning objectives today are understanding the definition of sepsis, SIRS, septic shock, identifying early recognition signs, outline the fluid and vasopressor management, apply infection prevention bundles, nurse-specific responsibilities, and a brief case discussion followed by MCQs. So the global burden of sepsis. WHO estimates around 49 million cases and 11 million deaths globally every year from sepsis. Sepsis accounts for 1 in 5 deaths worldwide, with higher mortality in low and middle income countries like India. In India, sepsis is a leading cause of ICU admissions and preventable deaths due to late recognition and resource challenges. Many cases are associated with healthcare-associated infections like CLABSI, VAP, and COTI that are preventable through good nursing practices. Role of ICU nurses. So being at the bedside, you guys are the first to detect early signs and prevent infection-related complications. Early recognition, communication, and rapid initiation of our one bundle directly improves survival. Nurses ensure compliance with infection prevention bundles, reducing the incidence of hospital-acquired sepsis. They also provide continuous monitoring and balance hemodynamics organ support parameters. So while understanding sepsis, the first step is to understand the three terms, which are SIRS, that is a systemic inflammatory response syndrome, sepsis, and septic shock. So SIRS is more than or equal to two abnormal vitals or labs. It could be either fever or hypothermia, tachycardia, tachypnea, leukocytosis, or leukopenia. So SIRS is a sensitive but not specific. SIRS can be present in many non-infectious causes also, like pancreatitis, burns, trauma, etc. Sepsis, on the other hand, is infection plus organ dysfunction. The mean arterial blood pressure could be less than 65, but not necessarily so. Whereas septic shock is sepsis with persistent hypotension requiring vasopressors. Septic shock is a subset of sepsis, and it is associated with profound circulatory and cellular abnormalities. Persistent hypotension with a MAP of less than 65 despite fluid resuscitation is important for an entity to be called as septic shock. So this is a simplified diagrammatic representation of what we just discussed. Infection plus SIRS, which is systemic inflammatory response syndrome, equals sepsis. Now, SIRS can have a number of other causes, which is pancreatitis, trauma, burns, whereas infection can also have a number of causes like bacteria, fungus, parasites, and viremia. When the Venn diagram of these two separate entities of SIRS and infection coincides, that is called sepsis. And septic shock happens to be a subset of sepsis. Septic shock, the common sources of infection could be skin, urinary tract, lung, or GI tract. In the blood vessel, when the bacteria enter into the bloodstream, it causes blood vessels to leak, and peripheral vasodilation, which causes hypotension. This hypotension is responsible for multiple organ dysfunction along with inflammation. So we have respiratory failure, kidney failure, liver failure, heart failure, and other clotting disorders. Pathophysiology of sepsis. So the infection leads to a dysregulated host response, which leads to extensive inflammation. This extensive inflammation causes vasodilation, increased capillary permeability, and intravascular volume loss. All of this ultimately leads to tissue hypoperfusion, metabolic acidosis, and progressive organ dysfunction, which affects the lungs, kidneys, brain, and heart. Now, what is a sepsis 1 hour bundle? This is an important slide. So, sepsis 1 hour bundle, basically, we remember this as removing 2 things from the patient and giving 3 things to the patient. So, first is measuring lactate levels. High lactate levels can signify possible organ perfusion which is compromised. Obtaining blood cultures, preferably before administering antibiotics. Administering broad spectrum antibiotics to the patient. Begin rapid fluid administration, crystalloid administration of 30 ml per kg for hypotension or when lactate is more than 4 millimoles per liter. And applying vasopressors if hypotension persists after fluid resuscitation to maintain a MAP of more than or equal to 65. So just to summarize, sepsis 1 hour bundle is measuring lactates, obtaining cultures before antibiotics, administrating broad spectrum antibiotics, 30 ml per kg crystalloid if hypotension or lactates of more than 4, and starting vasopressors if a MAP of less than 65 after fluids. So the common sources of sepsis in the ICU include pneumonia, including ventilator-associated pneumonia, bloodstream infections, which can also happen from central venous catheters, urinary tract infections, for example, 40, which can especially be seen after prolonged catheterization, intra-abdominal infection following surgery, trauma, or perforated viscus, and skin or soft tissue infections. Now, the red flag signs that the nurses need to know. First is hypotension, a MAP of less than 65 even after giving fluids. Altered mentation could be confusion, agitation, or a GCS of less than 15. We have oliguria, urine output of less than 0.5 ml per kg per hour for over 6 hours. Hypoxemia or tachypnea, which is characterized by a saturation SpO2 of less than 90% or a respiratory rate of more than 22 per minute. Mottled or cold peripheries is more of a yellow flag sign and it might indicate a possible early hypoperfusion. So we have many scoring systems in sepsis. Of importance to note, especially for nurses, is Q-SOFA or a quick SOFA score. It uses 3 bedside criteria, a respiratory rate of more than 22, or a systolic blood pressure of less than or equal to 100, and altered mentation. A score of, so each parameter is given 1 point. A score of more than or equal to 2 suggests a greater risk for poor outcome. We also have a SOFA score, which is a detailed score of each organ system and it helps in grading the severity and prognosis, while the Q-SOFA score helps in the rapid screening. So let's go ahead with the case. We have a case of sepsis with ARDS. We have a post-op patient who presents with hypoxemia and a rising FiO2 need. The nurse escalates early, draws culture, starts antibiotics, and assists in proning. The outcome here would be an early improvement in patient hemodynamics, and lesson is nurses are the bridge between detection and intervention. So the initial resuscitation, ABC of sepsis management. Airway, as we all know, airway is ensure patency, assist in intubation if indicated. Breathing, so apply oxygen, monitor saturation, and escalate to NIV or mechanical ventilation if needed. Circulation is gaining rapid IV access, preferably to large bore lines, 18 or 22, even 16 if possible, and prepare for fluids. Nurses initiate sepsis bundles. They ensure fluids and antibiotics are given within the golden 1 hour. Fluid resuscitation. So the surviving sepsis guidelines recommend giving 30 ml per kg crystalloids within 3 hours of hypotension or a lactate of more than 4. Fluids should be given as boluses with reassessment rather than a continuous drip. Nurses would monitor response via vitals urine output, mental status. And one thing of note is not all crystalloids are equal. Balanced fluids such as Ringer's lactate or plasma light are favored in ICU unless contraindicated. There is a low risk of acute kidney injury and better acid profile with balanced crystalloids. Normal saline, even though it is widely used, especially in resource limited settings, uh, theoretically it is said to cause hyperchloremic metabolic acidosis and it can lead to more kidney injury when given in large quantities. Monitoring fluid responsiveness. So the static measures of CVP, static measures like CVP alone are not reliable. Nurses should track urine output, MAP, lactate, and dynamic indices like pulse pressure variation or passive leg raise. Strict intake output charting is crucial in preventing volume overload. Periodic bedside reassessment helps guide therapy. Basically, nurses' vigilance equals safe fluid resuscitation. When do we start vasopressors? So, when fluids fail, if hypotension persists after adequate fluid resuscitation, that is the time to start vasopressors. The aim is to restore perfusion to vital organs. Nurses must recognize fluid refractory shock early and escalate quickly. So the first line agent in management of septic shock is norepinephrine or noradrenaline. The dosage is around 0.05 to zero point 0.1 micrograms per kg per minute and is titrated up. Some ICUs and institutions have their own protocols and we follow what goes on in our institution. This is just a guideline as to a starting dose. Norepinephrine has strong alpha-adrenergic effects, which leads to vasoconstriction and causes increase in MAP. Nurses must monitor blood pressure, check for arrhythmias, as well as IV line sight, especially when vasopressors like norepinephrine are given through a peripheral line. So, how do we titrate vasopressors? We always start with noradrenaline and we titrate up to maintain a MAP of more than equal to 65 millimeters of mercury. If noradrenaline is inadequate, we add vasopressin. Vasopressin is a fixed dose combination of 0.01 to 0.03 units per minute. Usually we go as 1.2 or 2.4 ml per hour. Consider adrenaline as an adjunct. And usually we avoid dopamine in septic shock unless there is a specific indication as use of dopamine is prone to arrhythmias. Vasopressor administration. So this is again an important slide. So the gold standard to administer vasopressor is central line. But in practical world, securing central line immediately for all ICU patients is not feasible. So the new survival sepsis guidelines indicate that if unavailable, a short-term peripheral infusion is acceptable via a large vein. Nurses must check the local site frequently for extravasation and flush lines carefully to prevent bolus dosing. Safety tip is to make sure that you never run vasopressors along with sedatives or analgesics. Cultures and antibiotics. So the timing of antibiotics, surviving sepsis guidelines always say that we give antibiotics within 1 hour of septic shock because early antibiotics administration saves lives. Every 1 hour delay can increase the mortality by 7 to 10%, which is significantly high. Obtaining blood cultures before starting antibiotics. Now, this is recommended, but only if it does not delay the therapy. Collect other cultures such as urine, sputum, or wound samples if clinically indicated, but never delay antibiotic administration for these. Proper labeling and asepsis to prevent poor results, and at least 2 sets of blood cultures should be drawn, and ideally from a peripheral vein and a vascular access device if present. Moving on to the antibiotics and source control. So source control examples include draining any abscess, removing the infected line, or debriding the wound. The role of nurses here is to prepare the patients, ensure a sterile setup, make sure the doctors follow the infection control practices, document and post-procedure monitoring. Source control is as important as antibiotics. Infection prevention in ICU. So I'm sure most of you are aware about these. Hand hygiene, the WHO 5 moments. We have you wash your hands or use a hand sanitizer before touching the patient. before aseptic procedures, after bodily fluid exposure, after patient contact, and after touching the surroundings. Strict hand hygiene can cut hospital infections by as high as 50%. Central line care bundle, so ensuring maximum barrier precautions at insertion, chlorhexidine antisepsis, daily line review, necessity of line remove lines early, aseptic handling and dressing care. Checklists ensures bundle compliance, and most of the institutions have their own specified checklists. And bundle compliance reduces the incidence of CLABSI. VAP prevention strategies. So we have strategies like elevation of bed to 30 to 45 degrees, daily station breaks or spontaneous breathing trials, oral care with chlorhexidine every 6 to 8 hours, and a closed suction system with subglottic suctioning to reduce the incidence of VAP. And then we have a COTI prevention. COTI prevention basically includes avoid unnecessary catheters, a closed drainage system, daily review of necessity and prompt removal, strict asepsis at insertion, and here the role of nurses is very important. Ensure that the doctors follow strict asepsis precautions, routine perineal hygiene, and maintaining a closed sterile drainage. Infection risk, well, the catheter infection risk can be minimized by nurses. And then we have antibiotic stewardship. A few important points to be mentioned here is avoid unnecessary antibiotics and monitor for de-escalation. Usually it is a part of the treating doctors, but nurses should be aware about these. Nurses to ensure that no missed doses and to monitor for reactions. Collaborate with intensivists in switching to targeted therapy. The right drug to a right patient at the right time is an important part of antibiotic stewardship. Oxygen and ventilation. So usually we start with supplemental oxygen to maintain a saturation of 90 to 96. Now this escalation is not for every patient. Escalation of oxygen strategies depends on individual case-to-case basis. But on an average, we usually move from a nasal cannula to a mask to HFNC or NIV and intubation. Nurses should continuously monitor saturation, respiratory rate, and ABGs. Watch for fatigue, increased work of breathing, and hypoxemia, and if any of these happen, escalate early. Renal support in sepsis. So in our ICUs, we see a lot of septic shock or sepsis patients requiring renal support, which is dialysis. So usually renal support in ICU or dialysis in ICU in septic patients is indicated when the patients have oliguria or acidosis or hyperkalemia or fluid overload or a uremic encephalopathy. Nurses, in some ICU setups, nurses help set up CRRT or intermittent dialysis machines and monitor filters. In our setup, we have dedicated nurses who handle CRRT and the SLED procedures along with dialysis technicians. It is important to be vigilant for clotting, electrolyte shifts, and hypotension during dialysis. Nutrition in sepsis. So it is usually recommended to start enteral feeds or RT feeds or nasojejunal feeds within 24 to 48 hours if the patient is stable. Parenteral nutrition is indicated only if the enteral nutrition is contraindicated or not tolerated. The role of nurses here is monitoring the gastric residuals, that is RT aspirations, tolerance of feeds, bowel sounds, and movements. Adequate nutrition improves immunity as well as wound. So nutrition in ICU is always a therapy and it is not optional. Nursing specific priorities. So here identifying 1 hour bundle, that is measuring lactates, obtaining cultures, giving antibiotics, giving fluids, and start vasopressors if needed. Ongoing assessments. So monitor the neurostatus, skin perfusion, urine output, and labs. Frequent GCS charging as well as perfusion checks. And structured communication helps to escalate effectively without wasting a lot of time and starting the therapy early. Accurate, timely documentation of vitals, interventions, and responses is very important because, as we say in ICU, if it is not documented, you have not done it. Sepsis complications, a short slide on these. So, acute respiratory distress syndrome can be caused as a complication of sepsis. We can have disseminated intravascular coagulation or DIC, which is bleeding plus clotting. Multi-organ dysfunction syndrome, which is failure of more than or equal to two organ systems. So that is the reason nurses must detect early deterioration, because sepsis, septic shock, it can involve all the organs of the body, and escalating care before there is an irreversible damage. More complication equals higher mortality, and it demands more vigilance. So, a quick slide on nursing challenges in low resource settings. We understand that there is limited access to labs, there is a limited access to vasopressors or renal replacement therapy or central lines. In resource limited settings, nurses rely more on clinical judgment, physical exam, and urine output charting. Using bundles adapted by resources such as early fluids, oxygen, and hand hygiene helps in reducing the mortality as well as morbidity in low resource settings. Innovation and vigilance save lives even without high-end resources. So moving on to the MCQ session, Dr. Rajan, I would like you to uh, coordinate here. I will be
Yeah,
reading the
so
first MCQ. Yeah,
yeah, so let's ask them if they have any question till now.
yes.
Then we'll move on to MCQs. So
Okay.
anyone has any question regarding the topic or anything, or should we go ahead with MCQs? Please type in the chat box. I think there is no question. I think we can move on to MCQs.
Okay.
Please carry forward.
So the first question here is, a patient with septic shock is on norepinephrine via a peripheral line. What is the nurse's priority action? I will read the four options. Option A, flush line with saline every 2 hours. Option B, check site frequently for extravasation. Option C, run norepinephrine with dextrose solution. And option D, add antibiotics to the same line for convenience.
Please type your answers in chat box. So there are three responses which says option B.
Very good. So you are correct. Option B, check site frequently for extravasation. So peripheral norepinephrine is risky and extravasation is monitoring is crucial with until central line access is secure. Second MCQ, which of the following is the most important nursing measure to prevent catheter-associated urinary tract infection? Option A, daily bladder scanning. Option B, routine prophylactic antibiotics. Option C, maintaining a closed drainage system. And option D, irrigating catheter every shift.
So majority of people is saying option C.
Very good. So it is option C, maintaining a closed drainage system. Closed drainage and early catheter removal are cornerstones of clot prevention. Third MCQ is, a nurse notes a BP of 85 by 50, which is hypotension, respiratory rate of 26, there is tachypnea, and a GCS of 30, which is altered mentation, and urine output of 15 ml per hour, which is also low. What does the Q SOFA score indicate here? Option A, 0, low risk. Option B, 1, low risk. Option 3, 2, high risk. And option 4, 3, moderate risk. So just a quick reminder, Q SOFA has 3 parameters and each parameter is given 1 score.
Okay, so majority is saying C. There are 2-3 people saying D also.
Okay. So it is high risk. Explanation, Q SOFA of more than 2. escalate immediately. MCQ 4. A nurse is caring for a ventilated patient with sepsis. Which of the following actions best reduces the VAP risk? Option A, keeping the head of bed flat for the comfort. Oral care with fluorhexidine. Routine suctioning every 2 hours, irrespective of need. Or early initiation of parenteral nutrition.
Okay. So majority is saying option B. There is one response saying C also.
Okay. So the correct answer is oral care with fluorhexidine, 6 to 8 hourly. Oral care as well as head of bed elevation are a part of evidence-based VAP prevention bundles. Fifth MCQ, which vasopressor is considered first line in management of septic shock? Dopamine, vasopressin, norepinephrine, or epinephrine?
I think everyone paid great attention. It's a simple one. And majority answer C, norepinephrine.
Very good. Very good. So it is norepinephrine. Norepinephrine is the drug of choice. Vasopressin and epinephrine or adrenaline are adjuncts. This is the last second MCQ. Which statement about infection prevention is correct? Nurses play a minor role compared to doctors. I do not agree with that. Hand hygiene reduces ICU infections by nearly 50%. Clepsy prevention requires only daily antibiotics, and VAP prevention depends only on ventilator settings.
Okay, so majority answers B.
Absolutely correct. So, hand hygiene reduces ICU infections by nearly 50%. And it is the simplest, most effective measure to reduce ICU infection. Final MCQ. A patient with pneumonia develops hypotension and confusion. The nurses initiate fluids, draws cultures, and administers antibiotics within 40 minutes. What principle is being applied here? Option A, sepsis resuscitation bundle. Option B, ventilator care bundle. Option C, antibiotic stewardship protocol or daily ICU checklist.
Okay, so majority answered option A.
Very good. So the answer is sepsis resuscitation bundle. Early recognition and initiation of 1 hour bundle defines sepsis bundle compliance. So the take-home messages of this talk have been sepsis is a medical emergency and early recognition and action in the first hour saves lives. Nurses play a vital role in detection, watching for red flags such as hypotension, tachypnea, altered mentation, and low urine output. Follow the 1 hour bundle. Prevent infections with strict hand hygiene and adherence to CLAPSI, WAP, 40 bundles, and reduce ICU sepsis. Teamwork is essential with effective communication and collaboration to improve outcomes. Since we have time, we can still, Dr. Rajan, can we take a few questions?
Yeah, sure, sure. So anyone has any question, please type in the chat box. Can't see any questions.
Okay. So thank you for
Thank
inviting
you
me.
for such a comprehensive and practical lecture, Dr. Supriya.
Mhm.